eye health. There's different roles of diabetes or different changes that can happen with your eye health because of diabetes. And then I'll talk a little bit about what you should be going to your eye doctor about, talking to them about, the information you should have when you go to see your eye doctor, and the questions you should ask, and then what your eye doctor should be doing with you every time you go in to see that person. So these are kind of the things we'll talk about to start with, the changes that we often see with diabetes. Kind of break it down and go into each one of those. The first thing that we often see is a shift in refractive error. Basically what that is a change in your glasses prescription. We oftentimes see this before the diagnosis of diabetes. And I was thinking about this last night. I had a patient, this probably been 3 or 4 years ago. This gentleman was probably in his late 60s, early 70s. Came in and he had just gotten glasses, I think it was in June. Did really well with the new glasses. Came back about 3 months later and couldn't see anything out of his new glasses, and he thought it was because of the new glasses. Well, his prescription had shifted 3 steps from 3 months ago. And that often happens with diabetes, sometimes with cataracts, but not usually that quickly. So we got him over here to his primary care physician. Turns out he had diabetes. After that went under control again, the new prescription was fine. But just that such a huge shift in his prescription, that was the kicker that we kind of indicated, you know what, that maybe his diabetes, and then sure enough it was. What happens is the blood sugars, when blood sugars are elevated for too long, it causes swelling in the lens inside the eye. I don't know how well you guys can see this here, but the lens is that part of the eye right there. It's right behind the iris, which the iris is the color part of your eye, so the lens is right behind that. The lens changes shape to help us focus. So when we go to look far away and read something up close, our lens changes shape to help us focus. When the blood sugar is too high for too long, that lens swells, gets bigger, and it causes a shift in your vision. So a lot of times we'll see that, whether before the diagnosis of diabetes or even if the blood sugar is doing a lot of this. If it's going up and down a lot, we'll see a lot of fluctuations in prescriptions. I've got a patient right now that I'm working with over the last few weeks that we just can't find a prescription for her that's stable. She'll come in 1 week and we find a prescription that she sees 20/20 with. She comes in the next week, we can get her to 20/20 again, but the prescription's completely different because her blood sugar is doing this. And her vision's kind of going right along with it. So we see that quite often. Ocular surface disease. The surface of your eye it's your cornea, and you've got a tear film on top of that. You see a lot of dry eyes with diabetes. And the reason for that is there's nerve damage and a decrease of blood flow to the gland, the lacrimal gland that produces your tears. So that damage to that gland, the gland isn't able to produce as much sufficient tears for the eye. It also decreases the sensitivity to the nerves in your cornea. Those are the nerves that tell your brain you need to produce more tears. So if the nerves aren't sending that signal to your brain's not sending the signal to that gland to produce more tears. Because we have a lot of trouble with people with dry eyes with diabetes. Pretty normal treatment for dry eyes. Start off with artificial tears. Especially with diabetics, we like to be preservative-free because the preservatives in a lot of those dry eye drops can cause more dry problems, more irritation. Ointments, sometimes we use those at bedtime. And then Restasis is a good new prescription medicine that helps your eyes produce more tears. Cataracts. Everybody gets cataracts, right? Everybody here? Eventually we all get cataracts. Diabetics typically get cataracts earlier in life, up to 20 years earlier in life, and typically they progress more rapidly. So we see diabetics with cataracts at a lot earlier in age, younger age than we do with people without diabetes. The other thing with the cataracts is cataract surgery is a pretty simple procedure to go in and take the cataract out to help the person see better, but it increases your risk of complications when you have the cataract surgery because of the diabetes. Again, it goes back to the ocular surface disease. You're making an incision on the cornea to go in there to take that cataract out, so that complicates the surface of the eye. There's always a risk of having edema, swelling in the back of the eye when you have a surgery like that. That risk is worse than when you have diabetes. We'll talk more about macular edema later on in the talk here, but that risk increases with diabetics. And then just with diabetes, you don't heal as quickly as you do as non-diabetics do. So the healing process takes a little bit longer with cataract surgery. Glaucoma, I don't see this a whole lot. Glaucoma and diabetes, the research says diabetics are twice as likely to have glaucoma as non-diabetics. In my practice, I don't see that anecdotally, I just don't see that as often as what this says. That's what the research says. And then there's a more severe case of a type of glaucoma called neovascular glaucoma that can occur because of complications from the diabetes. And that diabetes has to get pretty bad. You have to have pretty severe retinopathy before you get to that level. But it is a very severe type of glaucoma that can occur. So the two big ones that we really look for when we see diabetic patients are diabetic retinopathy and macular edema. These are the two biggies that cause a lot of reduction in vision and eventually in some people blindness. So some facts about diabetic retinopathy. We'll talk about what diabetic retinopathy is here in a second, but some facts about it. It's the leading cause of new cases of blindness in people ages 20 to 74 in developed countries. So it's pretty high incidence out there. You see 28.5% of people over the age of 40 with diabetes have some level of retinopathy. All right, 4.4% of those people with diabetes have retinopathy that's advanced far enough that they can have severe vision loss or blindness. That's a lot of people. That's a lot of people with pretty significant vision loss. The number one indicator for retinopathy, the biggest risk factor for retinopathy is the duration of diabetes. The longer you've had diabetes, the higher the risk is for retinopathy. A little bit more prevalent in men than women, more prevalent in African Americans and Caucasians. Bottom number here, $500 million a year annually related to diabetic blindness. That's a big old number there. It costs a lot of money to take care of retinopathy. So what is diabetic retinopathy? As we know, diabetes affects the small and large blood vessels in our bodies. The small blood vessels are the blood vessels that go to our kidney, that cause kidney disease, cause nerve damage, and retinopathy. The large blood vessels, the heart disease, and stroke. This picture, is there a way to turn off the front lights at all? Or I don't know how well you can see these pictures that I have, but the small blood, this is the back of my eye. These are the small blood vessels that feed your retina. All those little tiny blood vessels. That's what we're looking at with diabetic retinopathy. You guys see that okay? You see pretty well? Okay, that's okay, Deb.
Well, I think since that one is that better?
Yeah. You see a little bit better? I've got several more pictures that I want to tell you. So those are the blood vessels that we're talking about. Those tiny blood vessels in the back of your eye. Those are the ones that are affected by diabetic retinopathy. There's two different levels of diabetic retinopathy. There's non-proliferative. I have a hard time with that word. Non-proliferative diabetic retinopathy, and that's when the small blood vessels in the back of the eye start to swell and become leaky. And then proliferative diabetic retinopathy is when the abnormal blood vessels start to develop and cause additional bleeding in the back of the eye. We'll see more about that here in a second. Non-proliferative, there's three different levels of that: mild, moderate, and severe. Basically, it's just a continuum of starting to see some retinopathy, getting a little bit worse, and then worse yet. We don't have the new abnormal blood vessels growing yet, but it's just kind of getting worse over time. And I have a couple of videos that kind of explain this, and I'll see if I can get those pulled up here.
One form of diabetic retinopathy is called non-proliferative diabetic retinopathy, or NPDR. NPDR occurs when diabetes damages small blood vessels within the retina. These vessels start to leak both fluid and blood, gradually causing the retina to thicken or swell. Over time, the swelling or edema thickens the retina, causing the vision to become blurred.
So that's kind of what non-proliferative diabetic retinopathy looks like. So we see that quite a bit, and I've got some pictures here. Again, this is the normal retina. This one is kind of hard to see, but there's a couple of little hemorrhages, a little tiny one right there, larger one there, small spot right there. So this is real early, mild, non-proliferative diabetic retinopathy. And as we move forward, you can see a little bit larger hemorrhages throughout the back of the eye. Just kind of scattered hemorrhages where those blood vessels start to become leaky. And at this stage, really there's no treatment. And most of the time patients are asymptomatic. We really don't have any vision changes, not noticing any problems. but we're seeing those changes in the back of the eye. And that's where it starts to get kind of, that's where we need to really start to pay attention to where our blood sugars are. And that's the important thing, the reason why you need to see your eye doctor on a regular basis, because you don't have symptoms when you start to see these type of changes. But those changes, if they're not controlled and blood sugar's not improved or better controlled, those changes are going to get worse. And I'll show you an example of that later. So once we start to see the retinopathy, we probably need to have more frequent exams. We need to work with your physician on whatever it takes to get the blood sugar under better control. Working with a dietitian or a diet and exercise program that's going to help with your blood sugars. But at this point, typically no treatment other than controlling blood sugars. Proliferative diabetic retinopathy and diabetic macular edema. This is when the blood sugar or when the retinopathy gets to a level where it does change vision. Things you'll notice are loss of acuity, which is your sharpness in your vision. You start to see some floaters in your vision, distorted vision, loss of your field of vision or your peripheral vision, and eventually you can end up with blindness. I'll talk more about that. So the proliferative diabetic retinopathy is when you have so many areas where the blood vessels are becoming leaky, causing swelling in the back of the eye. You have parts of your retina that's oxygen deprived, and our bodies trigger these new blood vessels to grow. That's just the way our body thinks it needs to fix the problem, is by producing more blood vessels. These new blood vessels are leaky and cause a lot of bleeding in the back of the eye. They're real fragile. And then another video here that shows that.
One form of diabetic retinopathy is called proliferative diabetic retinopathy, or PDR. PDR occurs when new and fragile blood vessels grow abnormally from the retina into the vitreous. This can result in bleeding, scarring, and contraction of the vitreous, which may lead to retinal detachment. PDR can cause severe vision problems, and it can even lead to blindness. It must be treated as soon as possible.
So you can see those little tiny blood vessels start to develop, little kind of wiry, small blood vessels that are the walls of the blood vessels aren't very strong, they're real fragile. Over time, they end up breaking and allowing more blood into the back of the eye, which causes a lot of vision changes, as you can see. So in this picture here, you can see everything here, normal, non-proliferative diabetic retinopathy. You can see down here, kind of see those wiry blood vessels down there, and then this is where they cause a lot of bleeding. And that bleeding was probably caught fairly early, otherwise it would be more diffuse throughout the back of the eye. And then, just a kind of a depiction of what the vision would look like, normal vision with that type of hemorrhage in the back of the eye. Treatment for that type of retinopathy, proliferative diabetic retinopathy, is called pan-retinal photocoagulation. Basically, they go in and out. There's another video that shows this procedure, but basically, retinal specialist goes in and puts thousands of retinal laser scars to shrink and basically kill off those blood vessels that are causing all the leakings. They don't put the lasers in the central part of your vision. Right here in the middle is your macula, part of the eye that we use when you look right at something. They put laser scars there, you lose your vision. That's the downside to putting these laser scars in the eyes. So they put all these laser scars outside your macula, stops the bleeding, but you lose your vision, you lose your peripheral vision. All that part of the eye is responsible for your peripheral or your side vision. And I'll show you that last video here real quick.
One option doctors have for treating proliferative diabetic retinopathy is called pan-retinal laser photocoagulation, also called PRP. Using a laser, the doctor treats the peripheral retina where diabetic changes are causing damage. The macula, which is responsible for most of our vision, especially central vision, is not treated. The The procedure causes abnormal blood vessels to shrink and scar and prevents further growth of new blood vessels. However, more than one PRP procedure may be necessary. After the procedure, side vision may diminish somewhat, and night vision may be reduced. It is possible that central vision may be blurry for a few weeks. Remember that diabetes continues to affect eyesight and can lead to blindness if left untreated. It is important to see your eye care professional regularly. With early detection and modern treatment options, the threat of vision loss from proliferative diabetic retinopathy is far less than ever before.
I think I said thousands of laser treatments. I think more like hundreds of laser treatments. It does take a long time to go through all those laser scars in the back of the eye. And like the video said, oftentimes it has to be repeated if it doesn't stop all the bleeding. So, and I've been told it's very uncomfortable. A lot of patients the procedure itself isn't uncomfortable, but they have a lot of pain after the procedure. So it fixes the problem for the last side effects. And proliferative diabetic retinopathy can lead to vitreous hemorrhage. We saw that hemorrhage in the picture down here. This hemorrhage is if that hemorrhage breaks into the vitreous, which is kind of a gel-like substance that sits in front of your retina, it ends up looking like that. So it's almost like a snow globe with blood in it. It's all shooken up. So that vitreous cavity is filled with blood. And that's a real mess. Obviously, this patient doesn't see a whole lot out of that eye because he's looking through this red blood capsule. The treatment for that is called a vitrectomy, and they basically have to go in there with a couple different instruments to suck out that vitreous gel that's in there and replace it with either a gas or a fluid to replace the gel that you've just taken out. So a very invasive procedure to have go through to take care of this. Diabetic macular edema. This is swelling in that macula. So we talked about the macula being the center part of your eye where our good central vision comes from. Swelling from diabetes at any point can be non-proliferative, proliferative diabetic retinopathy. At any point, if it causes swelling in the macula, it's diabetic macular edema, and that causes vision change too because it's swelling right in the center part of your vision. You'll notice some blurred central vision. So you can see again on the left-hand side, normal macula, which is this area here. This part over here, all this kind of whitish yellow, it's called egg shape, is swelling in the macula area. This picture here, you can kind of see it a little bit better. This is called an OCT. This is the instrument that we use, the same instrument that the Wolf Eye Clinic uses to look at this part of the eye. On the left here again, normal macula. What this instrument does is it takes a laser and scans that tissue and then allows us to basically take that image and turn it sideways. So now we're looking at what's going on underneath the back of the eye, within the retinal layer. So again, this is what a normal OCT looks like in the macula. Over here you can see these kind of, they're called cystic spaces, where the swelling is causing the retina to thicken. I've got a couple more images like that too. So this one over here, this woman here, she's completely blind in her right eye from diabetic retinopathy. In her left eye, she still sees relatively well, but she's got this little spot here is a hemorrhage, and she's got some swelling right around it. So I see her about every 3 months to make sure that that's not getting any worse. This is the only eye that she's got at this point. So unfortunately for her, it stayed very stable, but it's nice to be able to have this piece of equipment to look at this every 3 months and see if this one's getting worse. This gentleman over here is, we talked about complications with cataract surgery from diabetes. He already had some macular edema prior to cataract surgery, but it wasn't this bad. This is where he ended up after cataract surgery. Again, going into the eye, he needed to have the cataract surgery done because he wasn't seeing much due to the cataract, but unfortunately, going into the eye and doing the things that had to be done to take the cataract out caused that swelling in the back of the eye to get worse, and unfortunately doesn't have very good vision today. And this is kind of, that was kind of an extreme case, but this is what you'd see with macular edema, normal vision over here, and just kind of a blurred, distorted vision on the right side there, macular. Treatment for macular edema, topical steroids, topical eye drops. If a person's already had cataract surgery, sometimes putting drops in the eye is able to get back to the retina well enough with just eye drops. Sometimes that helps with the macular edema, helps reduce it. Problem with that is you're on the steroids for a long time, and being on steroids chronically can increase your eye pressure, which can cause glaucoma. So you kind of really have to balance that out. But I do have a few patients with macular edema that are on chronic topical eye drops that we treat for the macular edema, and then we have to treat their eye pressure with different eye drops. So they're taking a lot of different medicines. Laser photocoagulation, again, it's that laser to zap the blood vessels where the bleeding is. They do this, and it's called focal laser, so they just pick out focal spots that are close to the macula, and you kind of see these little scars around the macula. Those are areas where the focal laser has been used. And then intravitreal steroids or anti-VEGF injections. You've heard of injections for macular degeneration, people getting shots in their eyes for macular degeneration. Same medicines that are used for macular degeneration have been found to help with macular edema as well. Those have been really good. With the laser scars, again, you've got scars, you've got loss of vision. With those injections, it gets rid of the swelling in the back of the eye without causing any permanent damage like a laser does. The only downside to it is typically you're receiving those shots every 4 to 8 weeks. You're making a trip to a retina specialist to receive those injections. Okay, so when you go to see your eye doctor, the information that we want to know when you come in to see us, so we can help assess where you're at and where you're going to be. Are you type 1 or type 2 diabetic? How long have you been diabetic? What's your treatment? Is it diet, exercise? Is it oral medications? Is it insulin? Is it a combination of those? Where do your blood sugars run? Do you keep a log of your daily blood sugars? If you do, bring that with you. It's nice to have a copy of that. Or what's normal for you? And your last A1C. And that's a big number. A lot of people remember it. Some people, I ask them what their A1C is, and they look at me like I'm foreign. They have no idea what it is. So that's a good number to know, and that's something you should be getting from your physician every 3 or 6 months anyways. You should be having that blood work done so you know where your A1C is. And that's a real good indicator for us of where what your risk is for retinopathy down the road. And then we want to know who your physician is. Do you see a family physician that treats your diabetes? Is it an endocrinologist? Who is it, and how do we get a hold of them? So we like to send letters to those people. So number one, we can tell them that you've been in for your eye exam, and number two, we can tell them where you're at, how well you're, if there's any problems with your retinopathy or anything else going on. What we will do, we'll check your vision. If your vision was 20/20 last time we saw you, and it's not 20/20 today, there's a reason for that. Is it because of your diabetes? Is it cataracts starting to form? What's going on there? So we'll check your vision. We'll do a refraction, which is just your prescription check for glasses. Again, if it's a big shift in prescription, it may be because the blood sugar's it's going up and down, or it's been high for a long time. We'll do a slit lamp exam, which is just the microscope over here. Look at the front of the eye. Dilated fundus exam, like this little lens here, lets us look into the back of your eye and see if there's any changes with your retina. Check your pressure. Again, I said it's pretty rare, but there is some changes that can happen that can cause that neovascular glaucoma. And then documentation, either photos or that OCT. The OCT was that scan that showed the swelling within the retinal layers. We've got both of those, and we use both of them on diabetics to document where you were today and compare that 6 months from now or whatever, and see if there's been changes over time. So we need to have documentation. And then we'll communicate with your primary care physician or your endocrinologist to let them know how you're doing. Prevention. Number one thing is controlling the blood sugar. All right? Like I said, from the onset of the disease, the sooner you can control your diabetes and keep those blood sugars under control, the less risk you're going to have for developing retinopathy down the road. Proper control of your blood pressure and cholesterol, proper diet and exercise, working with a dietitian. Walking 30 minutes, and I don't remember the exact statistic what it is, but there's a significant reduction in risk or development of retinopathy if you walk 30 minutes a day. And then at least a dilated eye exam every year. And that has to be every year. If you have any retinopathy, it should probably be more often than that. This is the one I told you I'd get back to. This is a patient I saw back in 2007. Again, it's hard to see. You can see these little dark spots here. A little bit of retinopathy, a little bit of hard AMD right there. This eye, again, hard to see. But some early diabetic, non-proliferative diabetic retinopathy. Didn't come back for 3 years. Couldn't see well. Came back in 3 years, and this is what we had. You can tell it's gotten a lot worse, significantly more hemorrhages, diabetic macular edema, both eyes. Unfortunately, that didn't get to the point where it was proliferative diabetic retinopathy, but definitely, some vision altering changes in the back of the eye. So that's why it's so important to get that checked every year. So if something like this starts to happen, it's caught early enough, and intervention can be taken. All right, questions? Yes.
I just have a simple question. Put it at the front. You meant, whoa.
Sorry.
You mentioned eye drops for dry eyes
Yeah.
that are
Non-preservative?
Yeah.
Yeah.
What exactly might those be?
You can find anywhere, if you go to a pharmacy and look for, the eyeball section that's got all the different types of drops, and there's hundreds of them there, I know. They will say preservative-free on them.
Okay.
So they don't come in bottles, they come in packs of
And vials, the little.
little tiny vials, yes. You
Yeah.
fill the top off of each
Okay.
vial. Yep, those are the preservative-frees. The reason why they're individual vials is because as soon as you take that lid off, it can become contaminated, and there's no preservative in there to keep it from becoming contaminated. That's why they do those little individual vials.
Do you have a recommendation of a preferred?
Theratears is a good one. Cystine is a good one.
Okay.
Genteel has one that's a good one.
Okay.
Any of those three.
Okay.
Optive. So
Okay.
there's several different ones out there. I like the preservative-free because the preservatives themselves, can keep it from becoming contaminated, but they can cause a lot of irritation.
The little vials, however, if you don't use all of it right away.
Yeah. The trick is you can fill that lid out, you can pop it back on.
Yeah.
Keep it where it's not going to get contaminated.
Okay.
Yeah. And usually it's pretty safe if you keep it by your bedstand. It's not going to get contaminated or.
There was an article, and I can't remember where it was at, that talked about a particular company like Allercon or Allergan.
Allergen?
And I'm not saying it's either one of those.
Yep.
But there was some issues that they didn't feel their quality was where it ought to be.
The quality of the teardrop?
They,
I'm not familiar with that.
okay, all right,
That article.
okay.
Huh. Where did you read that actually?
No, I don't remember, it's just a quick thing I'd seen in a little magazine. And it's been within the last 6 months, and I thought, oh, hadn't heard anything, hadn't seen.
Yeah, I haven't heard anything either.
Okay,
I'm not sure, I'm sorry.
so it must be that somebody complained a little bit.
Could have been. Very possible, yep. Was there another question? Yeah.
I I came to your office with Dr. Rhodes.
Yep.
Exam.
Yep.
And I was really surprised at how many pictures she had taken.
Yeah.
And I thought, do they do that with everyone these days? But it was because of my diabetes, is that correct?
Probably.
Okay.
Yeah, I mean, without seeing your chart picture, but I'm assuming that's probably the case.
Yeah, and by doing that, she did discover that I had some problems with my retina, and she referred me to the world.
Okay.
And as well as the cataracts that have been getting worse
Yeah.
for a lot of years.
Yep.
My long question here is, after the cataract surgery, I still have the retinal problem that they're following up on
Yep.
and examining. But I do not have, I have kind of a problem with my depth perception.
Okay.
Could that be more from the macular part or more from the cataract? The new
Did
lens.
you have cataract surgery on both eyes?
Yeah.
Yeah. It could be the cataract surgery depending on what your
The
prescription ended
lenses.
up being.
Well, I have a lot of problems. I have a toric type
Astigmatism.
astigmatism, yeah.
They put the toric implant in your eye?
Yes, they did.
Okay.
Mhm.
That could be it.
It's like the top of an insulin vial. When I go to put the needle in, and I think I'm putting it right in the center, half the time I hit
Hit the side.
the edge.
Yeah.
And
Yeah, it's hard to
but
say.
from what you were saying, I'm wondering if it isn't
you have some macular edema, that's possible that there's some.
That's what I'm wondering, if maybe,
If you have one eye that doesn't see as well as the other, you need both eyes to see well, to see good
Yeah.
depth perception. So if one eye doesn't see as well as the other, then you're gonna have some trouble with that. And that can be what it is too. If it's
yeah.
because of macular edema or some other retinopathy, one eye doesn't see as well as the other one. That
Oh, okay, so I should pay more attention to the macular.
Yeah,
cracks.
yeah, yep. And if you're seeing one of the retinal specialists involved, I make sure they're taking proper care of the other,
Yeah.
that treating properly,
Right.
so.
Okay, thank you.
Yep. Yes,
So, are you saying you should wait to have cataract surgery, or should you go ahead and have it done early because you have diabetes?
It's a case-by-case situation, and I kind of went to the extreme on these situations, you know, the patients that really have trouble with cataract surgery are patients that already have macular edema. So, if you have macular edema, there's some swelling in the back of the eye, have that conversation with your cataract surgeon. You know, what are the risks of this getting worse if I have cataract surgery? What are the risks if I don't have cataract surgery? You kind of have to weigh that out. If there's no macular edema, you know, still, the risk is still a little bit higher just by being a diabetic of having macular edema after surgery, but it's much, much lower if you don't have the macular edema prior to. So it's a good conversation to have with your surgeon. But if your cataracts are getting bad enough and your vision's just getting worse, you know, probably time to get it taken care of. Does that answer your question?
Yes, no. Okay, how common are floaters? I have a lot of floaters, always had that,
Yep.
even before I had diabetes.
Who has floaters? I mean, most people. Yeah, very common.
Very common, and see them all the time for a lot of the time.
Yeah. Yeah. If you have new floaters, the floaters look red, that's the biggest concern with diabetic retinopathy. If you have new floaters. Now, if you've got the same floaters that you've had for a long time, and they look about the same, and they're acting the same, they're probably just normal floaters. If you develop new floaters,
They'll be red.
well, it doesn't always have to be red, but sometimes, you know, if it's a red blood cell or if it's red, if it's bleeding, a lot of times it looks red. But if you have an onset of new floaters at all, get it checked out, because it may be related to the diabetes. Yep. Yes, sir.
Just in reference to your question, Wolf decided to do my cataracts first because then they thought they could get a better look at the retina.
Yep.
Because my cataracts were bad enough that it really interfered
Yep.
with getting a good view.
Yep, absolutely. And sometimes they can't do some of the treatments because of the cataract in the way as well. They can't see well enough to do some of the treatments in the back of the eye, such as laser. Hear that? Yeah, thank you. Any other questions? Well, thank you very much. My office is 2 blocks west of here. If you have questions, find me in the phone book, give us a call. We'll be happy to answer your questions, all right? Thank you.
Thank you.